Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the heart. Now, we introduced the external features of the heart in the lecture entitled Respiration, Pericardium, and External Heart. But in this lecture on the heart, we'll discuss the chambers of the heart, valves of the heart, coronary arteries, conduction system of the heart, and innervation of the heart. Now, I'll be back later for a clinical correlation and the end of session quiz, but for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
Each of the four chambers of the heart has distinctive features. The adult right atrium is derived from a pair of embryonic structures, the sinus venosus and the muscular atrium, that merge during development. The sinus venosus is a sac receiving vessels at the venous end of the heart tube adjacent to the primitive atrium. As these two structures develop and combine with each other, the venous structures that drain into the sinus venosus become incorporated into the posterior wall of the right atrium. When development is complete, the right atrium has a smooth posterior wall and a muscular anterior wall. The smooth-walled portion of the right atrium, which is derived from the sinus venosus, is called the sinus venarum. It receives the superior and inferior vena cava, the coronary sinus, which drains deoxygenated blood from the heart, and the anterior cardiac veins, which drain deoxygenated blood from the anterior wall of the right ventricle. The muscular portion of the right atrium forms its anterior wall, forms a pyramidal extension of the wall called the auricle, and surrounds the right atrioventricular or tricuspid valve. A prominent C-shaped ridge of muscle, the crista terminalis, which is a remnant of the valve that separated the sinus venosus from the atrium in the embryo, forms the anterior border between the two parts of the right atrium in the adult. The muscles in the anterior wall of the right atrium and in its auricle are called pectinate muscles. Pectinate is Latin for comb-like. The crista terminalis resembles the backbone of a comb, with the pectinate muscles extending from it like the teeth of a comb. There is a subtle indentation on the external surface of the right atrium over the crista terminalis called the sulcus terminalis. In the interatrial septum, the wall dividing the right and left atria, there is an indentation called the fossa ovalis, which is a remnant of a fetal structure, the foramen ovale. Deoxygenated blood collected in the right atrium passes through the tricuspid valve to enter the right ventricle. Most of the inner surface of the right ventricle is covered by muscular ridges called trabeculae carnae. The exception is the funnel-shaped part of this chamber leading to the pulmonary trunk, which is called the infundibulum. That's Latin for funnel, or the conus arteriosus. In the adult right ventricle, the part of the walls covered by trabeculae carnae is separated from the smooth-walled conus arteriosus by a prominent circumferential muscular ridge called the supraventricular crest. As you may have gathered from its name, the tricuspid valve, or right atrioventricular valve, has three cusps, or leaflets, that point into the right ventricle. The cusps consists of delicate connective tissue. The anterior cusp is adjacent to the anterior wall of the ventricle. The posterior cusp is parallel to the floor of the ventricle, and the septal cusp is adjacent to the interventricular septum. The papillary muscles, conical muscular projections from the ventricular wall, attach to the leaflets via tough fibrous cords, the chordae tendineae. The chordae tendineae branch several times and have extensive attachment sites on the cusps. The number and pattern of papillary muscles varies, but the most common arrangement seen in the right ventricle is 3 papillary muscles, each attached via chordae tendineae to 2 cusps. The anterior papillary muscle extends from the anterior wall and attaches to the anterior and posterior cusps. The posterior papillary muscle arises from the floor of the ventricle and attaches to the posterior and septal cusps. The septal papillary muscle is attached to the interventricular septum and is connected to the septal and anterior cusps of the tricuspid valve. Small accessory papillary muscles are common, as are occasional chordae tendineae that arise directly from trabeculae carneae. The septomarginal trabeculae, or moderator band, is a muscular bridge running from the interventricular septum to the base of the anterior papillary muscle. It carries fibers innervating this muscle from the conduction system of the heart, which will be described shortly. The moderator band ensures that the papillary muscle and the ventricular wall contract sequentially, the significance of which will be discussed now. When the ventricle contracts, the pressure of the ventricular blood pushes the leaflets of the tricuspid valve together, thereby closing the valve. The pressure of the blood within the contracting ventricle would push the leaflets of the tricuspid valve into the right atrium and open the valve, but the papillary muscles contract just before the walls of the ventricle, exerting tension on the chordae tendineae and preventing inversion of the leaflets. Thus, blood pressure closes the atrioventricular valve, while the papillary muscles and the chordae tendineae prevent the valve from prolapsing into the atria, thereby preventing regurgitation of blood from the ventricles back into the atria. The blood in the right ventricle is instead squeezed into the conus arteriosus through the pulmonary valve and into the pulmonary trunk. The pulmonary trunk bifurcates into the left and right pulmonary arteries, which carry deoxygenated blood into the lungs for oxygenation. The left atrium receives oxygenated blood from the lungs via two pairs of pulmonary veins and expels it through the left atrioventricular valve into the left ventricle. The left atrioventricular valve is also called the bicuspid valve, because it has two cusps, and the mitral valve, because its two cusps extend to form a peak, and thus resembles a mitre, the ceremonial headgear often worn by bishops. Like the right atrium, the left atrium has a smooth-walled portion that receives vessels, and a rough-walled muscular portion. Most of the left atrium is derived embryologically from the common pulmonary vein, and is thus smooth-walled. The part of the left atrium of the adult derived from the embryonic atrium is just the auricle, which is small and finger-like. Thus, the only part of the left atrium that contains pectinate muscles is the left auricle. There is no crista terminalis in the left atrium. The right ventricle drives pulmonary circulation, while the left ventricle drives systemic circulation, which feeds blood to the entire body. The latter, as you might imagine, requires more work than the former. Thus, the walls of the left ventricle are 2 to 3 times as thick as those of the right. The muscle fibers of the left ventricle are arranged in a spiral orientation that causes this chamber to twist when it contracts, effectively wringing blood out of the ventricle. When it relaxes, the left ventricle untwists, which creates a vortex that helps draw blood into the chamber. Most of the internal surface of the left ventricle is covered by trabeculae carneae, except for a short, smooth-walled superior region leading to the aortic valve, which is called the aortic vestibule. There is no moderator band in the left ventricle. The two cusps of the mitral valve, which point into the ventricle, are named the anterior and posterior cusps according to their relative position to each other. The posterior cusp is often incompletely divided into units called scallops. A variable number of papillary muscles attach to the cusps via chordae tendineae and perform the same function as they do in the right ventricle. Blood is forced through the aortic valve into the ascending aorta when the left ventricle contracts. The pulmonary and aortic valves are called the semilunar valves, according to their 3 half-moon-shaped cusps. The cusps of the semilunar valves are not attached to papillary muscles, and they are smaller and more delicate than the cusps of the atrioventricular valves. At the center of the free edge of each cusp is a small fibrous nodule. Along the edge of the cusp, on either side of this nodule, are two crescent-shaped areas called lunulae. The nodules and lunulae are parts of the cusps that contact each other when the semilunar valves close. Superior to the valves, the pocket-like spaces between the cusps and the wall of the vessel adjacent to them are called sinuses. When the ventricles contract, blood pushes the cusps of the semilunar valves away from each other and towards the walls of the vessels adjacent to them, thereby opening the valves. When the ventricles relax, gravity, negative pressure created by the dilating ventricle, and the elastic recoil of the walls of the pulmonary trunk or the aorta direct blood back towards the semilunar valves. The blood fills the sinuses and pushes the cusps of the semilunar valves together, closing the valves and preventing the blood from flowing back into the ventricles. The cusps of the semilunar valves are named according to their embryological origin, rather than their relative positions in the adult. The pulmonary valve has right, left, and anterior cusps, while the aortic valve has right, left, and posterior cusps. Each sinus is named according to the cusp forming its medial wall.
All right, it's time for that clinical correlation. Now, Dr. Phelan didn't get into the physiology in depth, so I want to briefly describe some heart physiology as it relates to heart sounds before we move on with the lecture. Now, you've probably noticed that physicians and other healthcare professionals carry a highly conspicuous stethoscope in their lab coats. Now, we use this instrument to listen to the sounds generated by the valves of a beating heart, amongst other bodily noises like breathing sounds and bowel sounds and that sort of thing. But we're always listening to that heart because it's important. Now, you'll learn an incredible amount of information about the cardiac cycle when you take a physiology course, but we're going to simplify the discussion of this topic considerably. Now, when the ventricles are filling with blood, the atrioventricular valves are open and the semilunar valves are closed. Now, this phase of the cardiac cycle is called diastole. To help you remember that, the ventricles are filling during this phase, you might consider that the ventricles are dilating during diastole. Now, an electrical impulse is generated by the SA node, which is then distributed by the AV node and then to the AV bundle and the subendocardial branches of the right and the left bundle branches, and ultimately it reaches the ventricles. Then the papillary muscles contract to put tension on the chordae tendineae, and then the walls of the ventricle contract. Now, this phase of the cardiac cycle is called systole. Now, blood pushes against the leaflets of the atrioventricular valves and causes them to contact each other, while the papillary muscles and the chordae tendineae keep them from separating and inverting into the right atrium. Now, the sound generated by the leaflets impacting each other as the atrioventricular valves close is often described by people to listening through a stethoscope as a lub. So while the ventricles do not contract exactly simultaneously, their contractions occur close enough that they produce a single heart sound in unison. Now, since blood can't travel through the atrioventricular valves, it is instead forced by the contraction of the ventricle through the semilunar valves into the pulmonary trunk and the ascending aorta. Now, at the end of systole, the ventricles relax and the atrioventricular valves open. Blood travels backward through the pulmonary trunk and the aorta due to the elastic recoil of the walls of these vessels and also because of gravity and the negative pressure produced by the relaxing ventricles. And then this fills the sinuses of the semilunar valves. The cusps of the semilunar valves come together and these valves close. Now, the sound made by the delicate semilunar cusps impacting each other as the aortic and pulmonary valves close is softer than the sound produced by those larger, sturdier leaflets of the atrioventricular valves. And then through the stethoscope, you hear a dup. So to summarize, the sound produced when the atrioventricular valves is this lub. And then the sound produced by the semilunar valves is sort of a more delicate dup. So lub dup, that sort of thing. So if a valve does not close completely, perhaps due to a ruptured papillary muscle or a defect in one of the cusps, the sound of the blood being forced through the orifice of an incompetent valve may be detected as a murmur. So by placing the stethoscope at different points on the thoracic wall, the sounds produced by each individual valve may be detected. This process is known as auscultation of the heart valves. Now, the best place to listen to the semilunar valves is the second intercostal space, just to the right of the sternum for the aortic valve and just to the left of the sternum for the pulmonary valve. Now, the right atrioventricular or tricuspid valve is best auscultated at the fifth intercostal space, just to the left of the sternum. Placing the stethoscope over the fifth intercostal space at the mid-clavicular line, which corresponds to the location of the apex of the heart, is a good way to listen to the left atrioventricular or the mitral or bicuspid valve. Okay, so let's go over some of these questions now. In a normal heart, what is the sound produced when the atrioventricular valve closes? And also when the semilunar valve closes. So atrioventricular is the lub, and then the semilunar is the dup. Next one, in a normal heart, where on the thorax could the mitral valve be heard best? So you can see from the image here, it is at the left fifth intercostal space in the mid-clavicular line. Now let's move on in our discussion now, and let's move on to the coronary arteries in the lecture.
The ascending aorta begins at the orifice of the aortic valve and ends at the proximal end of the aortic arch, which is found at the level of the transverse thoracic plane, which corresponds to the sternal angle anteriorly and the disc between thoracic vertebra 4 and 5 posteriorly. The only branches of the ascending aorta are the right and left coronary arteries, whose origins are found in the right and left aortic sinuses. The posterior cusp of the aortic valve is called the non-coronary cusp because no coronary artery arises from its sinus. Blood flow is highest through the coronary arteries when the ventricles relax because, as mentioned previously, blood flows backwards through the aorta and fills the aortic sinuses, where the coronary arteries originate. The coronary arteries supply the heart. Their branching pattern varies widely, but we'll describe the most common patterns. The right coronary artery enters the coronary sulcus on the right side of the heart and in about 60% of hearts gives off a sinoatrial nodal branch that supplies the sinoatrial node, an element of the conduction system of the heart which will be described shortly. Near the inferior border of the anterior surface of the heart, the right coronary artery gives off the right marginal branch, which runs horizontally along the inferior edge of the anterior surface of the heart. The right coronary artery follows the coronary sulcus to the posterior side of the heart, and as it approaches the intersection between the coronary sulcus and the posterior interventricular groove, it gives off the atrioventricular nodal branch, which supplies the atrioventricular node, another component of the conduction system of the heart. In more than 2/3 of all hearts, the right coronary artery then gives off the posterior interventricular artery, which travels within the posterior interventricular groove. In this case, the heart is said to be right dominant. If the posterior interventricular artery branches from the left coronary artery, the heart is said to be left dominant. The posterior interventricular artery supplies the interventricular septum and adjacent parts of both ventricles. The right coronary artery then continues for a short distance in the coronary sulcus before terminating. The right coronary artery supplies the right atrium, most of the right ventricle, the diaphragmatic surface of the left ventricle, the posterior part of the interventricular septum, the sinoatrial node in about 60% of hearts, and the atrioventricular node in about 80% of hearts. The left coronary artery begins in the coronary sulcus on the left side of the heart and runs deep to the left auricle. It bifurcates into a circumflex branch, which remains in the coronary sulcus, and the anterior interventricular branch, which descends in the anterior interventricular groove. The anterior interventricular branch is most commonly referred to clinically as the left anterior descending artery, or LAD. It often gives off one or more parallel branches called lateral or diagonal branches that run along and supply the left ventricle. The anterior interventricular branch descends to the apex of the heart and usually continues in the interventricular groove to the posterior surface of the heart, where it anastomoses with the posterior interventricular artery. The anterior interventricular artery supplies the anterior portion of the interventricular septum and adjacent parts of both ventricles. As it approaches the posterior side of the heart, the circumflex branch gives off a sinoatrial nodal branch in about 40% of hearts. It then usually gives rise to a lateral marginal artery that drops out of the coronary sulcus and runs along the left border of the heart on the surface of the left ventricle, which it supplies. The circumflex branch continues in the coronary sulcus on the posterior side of the heart and usually terminates before reaching the intersection of the coronary sulcus and the posterior interventricular groove. In a left dominant heart, however, which represent less than a third of all hearts, the circumflex branch turns to enter the posterior interventricular groove as the posterior interventricular artery. Typically, the left coronary artery supplies the left atrium, most of the left ventricle, part of the right ventricle, the anterior 2/3 of the interventricular septum and the parts of the conduction system of the heart that run through it, and in about 40% of hearts, the sinoatrial node. Most of the venous drainage of the heart is accomplished by veins that empty into the coronary sinus, a wide venous channel that runs in the coronary sulcus on the posterior side of the heart and opens into the sinus venarum of the right atrium. The three main veins received by the coronary sinus are the great cardiac vein, the middle cardiac vein, and the small cardiac vein. The great cardiac vein begins at the apex of the heart and ascends through the anterior interventricular groove with the anterior interventricular artery. Superiorly, at the point where the anterior interventricular groove intersects with the coronary sulcus, the great cardiac vein turns left to enter the sulcus and travels within it alongside the circumflex branch of the left coronary artery. When it reaches the posterior surface of the heart, it becomes continuous with the coronary sinus. The great cardiac vein drains the areas of the heart supplied by the left coronary artery. The middle cardiac vein runs in the posterior interventricular groove alongside the posterior interventricular artery. Clinically, the posterior interventricular artery is most often referred to as the posterior descending artery, or PDA. The small cardiac vein runs in parallel with the right marginal branch of the right coronary artery. Together, these veins drain the area of the heart supplied by the right coronary artery. Several anterior cardiac veins drain directly from the anterior wall of the right ventricle into the right atrium. Additionally, there are numerous vena cordis minime, or Thebesian veins, that originate in the walls of the heart and drain directly into all four chambers. When the heart is disconnected from the central nervous system, it continues to beat as long as the tissue is kept viable. This must mean that the heart has an intrinsic nervous system, and it does. It's called the conduction system of the heart. The impulse that initiates the coordinated contraction of the myocardium is generated by the sinoatrial node, a collection of specialized cardiac myofibers that simultaneously and spontaneously depolarize about 70 times per minute. This node, which is also called the SA node, is commonly referred to as the pacemaker of the heart. It is named the sinoatrial node because it is located on the border of the sinus venerum and the muscular portion of the right atrium, about where the superior end of the crista terminalis intersects with the inner surface of the superior vena cava. Autonomic nerves converge on the sinoatrial node to regulate the rate at which its cells depolarize. The impulse generated by the sinoatrial node spreads out through the walls of the atria and causes the muscular portions of these chambers to contract. The cardiac muscle of the atria conducts the electrical signal and transmits it to the atrioventricular node, or AV node, which is smaller but otherwise similar in composition to the sinoatrial node. It is located superior to the opening of the coronary sinus in the interatrial wall. The atrioventricular node distributes the electrical signal to the ventricles through the atrioventricular bundle, which extends from the node. The bundle is made up of cardiac fibers that are specialized for conduction. It penetrates the right fibrous trigone of the fibrocartilaginous skeleton of the heart and enters the interventricular septum, where it splits into left and right bundle branches at the junction of the membranous and muscular parts of the septum. The bundle branches travel through the muscular parts of the septum and divide into subendocardial branches, which consist of highly conductive Purkinje fibers that run in the myocardium just deep to the endocardium. The subendocardial branches of the right and left bundle branches innervate the walls of the respective ventricles. Additionally, Purkinje fibers from the subendocardial branch of the right bundle branch pass through the moderator band to innervate the anterior papillary muscle. Autonomic innervation from the central nervous system changes the rate at which the heart beats. Sympathetic nerves from the upper thoracic levels of the spinal cord and parasympathetic nerves from the vagus, or 10th cranial nerve, combine to form the cardiac plexus, which is found anterior to the bifurcation of the trachea and posterior to the ascending aorta and bifurcation of the pulmonary trunk. Branches from the cardiac plexus end in the sinoatrial and atrioventricular nodes and also innervate the smooth muscle of the coronary arteries. Sympathetic innervation increases heart rate and force of contraction and dilates the coronary arteries. As you might imagine, parasympathetic innervation decreases heart rate, decreases the force of myocardial contraction, and constricts the coronary arteries. The heart is insensitive to touch and temperature, but ischemia and the corresponding accumulation of metabolic products stimulates pain fibers in the myocardium. These pain fibers travel in the sympathetic nerves supplying the heart, especially on the left side. The pain is felt in the dermatomes supplied by the spinal cord levels from whence the sympathetic nerves originated. The left T1 through T3 dermatomes, which extend across the upper thorax, across the shoulder, and down the medial side of the upper extremity, are the areas where cardiac pain is most often referred to.
Okay, so that wraps up our discussion on the heart. Now I want you to pause the video and answer all the end of session quiz questions, and then we'll go through those answers together. All right, let's get going. What are the other names for the posterior descending artery, the PDA, and the left anterior descending artery, the LAD? So the PDA is the posterior interventricular artery, and then the LAD can sometimes be referred to as the anterior interventricular artery. Next, what is the difference between a normal heart, a right dominant heart, and a left dominant heart? So normal heart, the right and the left coronary arteries supply the heart equally, and a right dominant heart, the right coronary artery supplies the right ventricle plus part of the left, in many cases by an elongated RCA or by giving rise to the circumflex branch. Left dominant, that left coronary artery supplies the left ventricle plus part of the right, and in many cases by giving rise to the PDA, or in the absence of a PDA, by an elongated LAD. Next question. Which vein runs with the LAD, PDA, and marginal artery? So LAD, we have the great cardiac vein. With the PDA, we have the middle cardiac vein. In the marginal artery, we have the small cardiac vein. Next, what attaches the papillary muscles to the heart valves? That's the chordae tendineae. Next question. Which muscles contract first during a heartbeat? The papillary muscle or muscles of the ventricular wall? So the papillary muscles contract before the muscles of the ventricular wall to ensure that the atrial ventricular valves are not closed and blood does not regurgitate back into the atria during ventricular contraction. Okay, so we're almost done. Now we've provided some images for you to label. Recalling these images in a time setting will help you perform well on the practical part of your examination. So label those images and then we'll be finished. Thanks.